So first we have Dr. Carolyn Babar, who completed her undergraduate degree and residency in Saskatchewan, and then she worked there as a hospital pharmacist before she moved to Toronto to do her pharmacy at U of T. And now she's moved to White Rock with her family. She works at Peace Arch Hospital and is a clinical pharmacy specialist in geriatrics. So that means she focuses mostly on the acute care for elderly unit and supports patients in the associated long-term care facility through care conferences and regular medication reviews. And she also presets UBC pharmacy students and hospital pharmacy residents. So welcome, Carolyn. We also have joining us Hafeez Dossa, who is a pharmacist here, pharmacy manager and pharmacist here in Nanaimo, and he works with CareRx, which is a pharmacy that services many of the long-term care facilities on Vancouver Island. And he did a Bachelor's of Science in Biomedical Physiology at SFU, and then later a BSc in Pharmacy at UBC. And I haven't met Carolyn in person before. I see today she's full of energy, and from her work I can tell she is, and I know Hafeez is as well. He told me that he traveled to Australia and New Zealand and did some extreme sports like skydiving and heli hiking, and he's taken a lot of that energy after taking a break to go do that traveling and applied that into tackling pharmacy in the facilities that he's supporting. So in addition to doing the medication reviews, he also has done a number of projects around deprescribing, particularly things about antipsychotics, antihypertensives, dementia medications, and most recently PPIs. So welcome both. It's really a pleasure to have you here, and I'm excited to talk about some of the work that you've done. Just before we do that, I wanted to declare that none of us have any commercial conflicts of interest. Members of the TI receive a small salary from there, and Carolyn has a pharmacy from Fraser Health and a Lower Mainland Pharmacy Services, and of course Hafeez's salary comes from CareRx. And if there was any perceived bias, we hope that we are providing references for any facts that we're giving, but also encouraging a dialogue through discussion. Okay, so I'm going to jump right into it, and like I said before, hopefully it's a conversation that helps inform you of how to do this in your own practice and potentially expand this into other medications. And just a quick reminder, I think there's still a little bit of sound. I know many people working from home. Hopefully you can just mute your microphones to make it a little bit easier to discuss. So I wanted to ask Hafeez first, what was it about proton pump inhibitors, or why did you start tackling those?
So PPIs was, when I first started working in the long-term care setting, I noticed, people were taking just a ton of medications, and it's standard for people to have a lot of comorbidities at this stage, but I kind of reflected on some of the indications that might be there, and PPIs was always the one that stuck out as, do they really need to be on this? Because something such as Gerd could be treated with medications, but also lifestyle modifications. And so when I looked at PPIs, I figured, okay, maybe this is something that we could target. We could look at doing a project on something like this to really focus in on what we're able to do in the long-term care setting as a cohort. And so that's why I chose this one. And the other reason is because there's a lot of things that we look at deprescribing. I know Jessica has experience in long-term care, and there's a lot of things that at this stage of care we look at potentially focusing more on quality of life and comfort care. But the thing with some of the other medications, such as antihypertensives, for example, the risk of deprescribing an antihypertensive is kind of like a scary thing, like a heart attack or a stroke or something like that. But the PPIs are kind of a good starting point, because unless someone has a history of a GI bleed or something that's more severe, which we'll touch on a bit later when I looked at the categorization of indications, generally PPIs are for something that's more mild or something that's not going to be as traumatic as deprescribing an antihypertensive, for example. So that's kind of the second reason why I chose PPIs.
Yeah, that makes a lot of sense. Some say low-hanging fruit, if you're having a hard time getting started. Carolyn, how about you? Were there other reasons that inspired you to look specifically at proton pump inhibitors?
Very similar, I think, to what Hafeez mentioned. The only thing I think of to add is that I think as a group within Fraser Health, there was an initiative to address polypharmacy, and we met regularly with the physicians and medical directors and went over a lot of our stats. And there was a lot of specific programs and procedures in place to target things like antipsychotics and antidepressants. And PPIs, there was really nothing kind of specific. We were just sort of, it was out there, but we didn't have a way to really look at that or even know how many people we had. And so it seemed like a relatively straightforward and pretty easy thing that we could get the information. Yeah, and we had the support of the group to do it at that meeting, so we thought, we'll just see where we're at with that. That's where we started.
That makes a lot of sense. And I noticed that neither of you were strongly emphasizing the harms of PPIs as a real concern, other than as a part of polypharmacy. And I think that's probably common. We understand very little about the harms because the randomized controlled trials just don't exist to tell us about that. But because there are some scary associations, including increased mortality and so on, it's obviously an area that's going to be looked into further. And as you say, these are not necessarily life-sustaining drugs, so maybe easier to tackle. Okay, well, I'm sure there's lots of good reasons to take a look at them, but it's interesting to know what drove you specifically. And so once you have these ideas in your head of, okay, I want to do something around deprescribing or reducing PPIs, obviously you had to come up with some sort of process of how you would do that logistically. So maybe, Carolyn, you could tell me about how you started thinking about doing this?
So our hospital has, at the time in 2018 when we first looked at this, there was 2 facilities that were on our campus of our hospital that our pharmacy supplies medications for, and also we support the clinical services there. So the first thing I did was I just basically created a list that I generated through the hospital medication system to tell us who were the residents, how many did we have, where were they located, which physicians were responsible for their care. And once we gathered that, so that was something I could do in about 15 minutes. It was very quick. Then I just went through and reviewed those residents and sort of grouped them by physician. So we had one medical director at each of our 2 buildings, and then they're responsible, I would say, for about 80% of the residents in those buildings. And then there was a handful of other family physicians that still had some of their own patients in the facility. So overall, we had about 7 doctors. So I basically just went through and kind of grouped together for each doctor who their residents were, what were they on, what could I tell from the medical record about what they were on it for, and just summarized all that for them. And when I would see them in person every week, I would talk to them about it and give them a copy of who their residents were to address. And they also had a chance to have a sneak peek at their colleagues and see how many other residents in the building were on PPIs and kind of compare themselves to their peers, which they seem to be very excited about being able to do. That seemed to be interesting information for them.
That is interesting, and again, the Therapeutics Initiative is using that competitive spirit as well with the prescribing portraits that are going out to mostly family physician prescribers in BC. Hafeez, were there other things in your mind did you come at this from a different angle when you started thinking about how you might get it started?
Yeah, so for me, when I started doing the medication reviews and care conferences and kind of thinking about deprescribing, this was something that was already being done. So when I was doing a med review or a care conference, I would flag a PPI. Are they having symptoms? How long they've been on it? What's their diagnosis? Do you think they need it? Let's taper this. Let's stop this. So that was kind of something that was just part of the routine. It was something that was already happening. And one day I just said, I feel like if we were to quantify this, I think it would be quite significant. So the solution was essentially something that was already occurring, but it was just kind of making it more structured and making it more, I guess, tabulated so we could see what the impact was. And then similar to Carolyn, right, just generating a list. I broke them down by category. So when we go a bit further into the conversation here, I had 5 categories that I had residents who were on PPIs kind of put into. And then I would send letters to the physicians and explain, this patient is taking this PPI. These are the risks associated with PPI use. it's recommended to do a reassessment after a year if it's for Gerd, all those sorts of things, and then just made it really simple. Like simplicity was the main thing for me, just to make it really easy for the prescribers to be able to see, you know, what's the purpose of this? Okay, this makes sense. Okay, sounds good, and then you move on. So you know, every category I had a specific letter that had certain recommendations, whether it was a taper or switching to another medication, and so that was the process for designing it. But I think the main thing was it was something that was already being done. It was just a matter of putting it into more of a project type of thing.
Yeah, it sounds like both of you had, you know, even Carolyn, you had sort of feelings of this prescriber kind of was more interested or already engaged in that work, and, you know, others maybe needed a bit more of a nudge. So both of you were trying to formalize that and encourage, you know, what could be. And I think I've got a couple of slides from you, Hafeez, just talking about what your implementation looked like. And maybe we could just move on to those. And these are some of your points. Do you mind sharing those key points with the group in designing this?
Yeah. So we had about 400 residents that we were servicing at the time, and so I ran a report similar to Carolyn, where, you know, about 25% of the patients were taking PPIs. So approximately 100 people that had PPIs on their profiles. And so what I did is I went through those 100 patients, and I gave them a category A through E, and we'll touch on the specifics of that a bit later. But so first, I categorized each patient. You know, they have no indication, or they have a severe indication, or they're diagnosed with Gerd, or they're taking it for prophylaxis with ASA or NSAIDs, or whatever the case was. And I know it sounds really tedious, but after this, then I sent a letter to all these physicians saying what category they were in, you know, why we were doing the study, why we were doing the project, sorry. And this is an example of one of those letters. So, yeah, one of these letters was sent to all these physicians. I think it was 88 letters or something like that. And you can see there, I gave a summary of you know, the different categories that a patient could be in, and then let them know what the dose was that the patient was taking, and then had some recommendations, or, you know, if there was a reason that someone should be taking a PPI long term, then they were able to justify that. But pretty straightforward letter. So that was that part of it. You can probably jump back to the previous slide. And then, yeah, so after sending the letters, you know, after the intervention was done, I made sure to follow the patients to see if they had successful deprescribing afterwards, and then that was the follow-up report, and then we'll look at the statistics after that. So
and
that was the procedure that I used.
Okay, how did you send those letters? Was that in the mail or by fax, or what was the?
It was by fax, yes.
By fax, okay. And maybe a question for Carolyn. It sounds like you know, you did some categorization and looking at the data. Some of that was quick. Some of that was probably a lot more involved. Did you have help? Were there other people in the team that helped you organize your intervention?
So back when I started it, I really just, I guess my approach to it was a little bit less formal. I didn't really create a letter or anything. It was just discussions that I had with the physicians in person when I'd see them. And I'd know these are your 10 people. Do you have time? Let's talk about a few of them. And then we would, and I'd usually take a verbal order from them at that time if we thought we could deprescribe, and we'd kind of just get through them as we saw each other. But in the fall, so this took place all across the summer, and then in the fall I got a directed studies student, Rachel Tandon, to come and work with me, and I worked with Erin Tajani as well. So we went back, and she went back to look to see, to just gather some more of the details of those residents so we could give some more information about how old they were and what other comorbidities they had, and just sort of try to add to the data about who these residents were and how successful we were in what we were trying to do.
And so did you, I'm trying to picture, did you walk around, you had like a list of naughty doctors, or
Oh, no.
I'm wondering how, you know, because I've been that doctor where the pharmacist corners me and, hey, we need to talk about this. So how did you make sure you were addressing every resident or patient rather's needs, and just being thorough? Obviously, you did have a mechanism.
The majority of the patients were under the care of the medical director, who is the doctor I would see every week. So we have a good working relationship. We see each other at least once a week in person. So those ones were very straightforward because we just talked about them in person. And there were a handful of other doctors who maybe would only have 2 or 3 residents each. And I would have to sort of know, well, when are they going to be coming in for a care conference for their residents so that I could make sure that I had enough time to speak to them in person. I actually found for myself that speaking to them in person was the key for me. I felt like because then we could have a discussion back and forth about it. And we'd have the chart there, and the resident is there, the nurses are there. So I tried as best I could to always do it in person. However, there were a few doctors who, because it took place over the summer, I didn't get a chance to run into, or they had 1 resident. And so there was, I think, 2 or 3 doctors that I ended up faxing or calling on the phone. I tried my best to do it in person because I did find that was the most effective.
Okay. And just building on that, Carolyn, I don't know, were there any barriers or places where you really got stuck, where you had a hard time moving forward with these conversations?
I think the biggest barrier that we found trying to address it, like the physicians and myself, was that we often didn't really know why the resident was on it in the first place. So, I'd go back through the hospital medical record as far as I could. We'd pull some of the old charts and look if we could. And sometimes it was started and we had to assume we could kind of know why it was started based on the other medications they were on or some of their medical history. But and I think it was almost 26% of the people, even after a pretty good review of the EMR and all the records we could find, we had no documented indication. So that makes it hard to know if it's safe to stop. So, and you had to really do a lot of digging to find the indications that were there sometimes too. And that's time consuming, and for a busy doctor, and if they feel that they are not got all the information to make the right decision, sometimes I think the feeling is the safest thing is to just leave it alone. So I think maybe what I added was I took the time to sort of do some of that digging around for them so that I could supply that information so we could make a decision about it.
Well, that makes sense. Yeah. I'm just going to pause for a second. I'm trying to monitor the chat at the same time. I know there's some requests for showing the letter that's come up. And Hafeez has been kind enough to provide that. So it's actually on the website, so you can take a look at it there. So I won't be showing it again right now, but later I'll show the link to the TI website, which has a PDF version of that for you to take a look at. And hopefully that helps. And the other question is about patients, and I think that's really important. This is from Carolyn Canfield, and I know Erin's gathering some of these, but I think it's relevant and for either of you. Did you find that patients' families or patients themselves had an interest in these drugs? Were they the ones that prompted deprescribing? Did they have any worries about being taken off the medication?
Well, I think, whenever we have care conferences and medication reviews, people are generally pretty thrilled about this being a big part of what we're doing. I mean, there's definitely going to be some people who are on the other side who they feel, I'm not having any problems, why mess with what's working? But then I think when you have a discussion about, risks of side effects or even costs for patients who don't have special authority or pill burden, these are things that it's important for pharmacists to have the discussions with the patients and the care providers and even the physicians and the nursing staff. So it's all interdisciplinary, and I think these are things that, for the majority is positive, but with anybody who sees it kind of more in a negative light or maybe even kind of indifferent about it, it gives us an opportunity to really change the way that people see the role of medication. So.
Wow, that's pretty huge. You're starting, like as you said at the beginning, both of you starting with something that's a little easier and kind of gradually gaining ground and trust and there. Carolyn, did you have anything to add?
One of the other challenges, I guess, that I didn't think of to mention earlier is just that a very large proportion of the residents have dementia, and so that does make it challenging to monitor. Do they really understand why they're on it? Can they really tell us if the symptoms recur? So those were challenges, and so some of the discussions around deprescribing were with family members rather than the resident themselves, and so I can't think of any time where anybody objected to that, especially since we were always sort of broach it as, if the symptoms recur or we have any concerns, then we can always go back and we can always go back on it. But the only way to know if it's safe to come off is to just try and see how it goes. So I found people to be very open.
Yeah, I can touch on that as well. Just in terms of kind of the resistance potentially for any symptom recurrence. One thing that I tried to do in some cases was, you know, if we were going to do a taper, for example, for 2 weeks or 4 weeks or whatever the case was, we would do a taper, but we'd also add a PRN order that they would have. So, you know, if it was one day and it was that late at night or in the evening, and you know, they needed a dose because of symptom recurrence, they could take a PRN. They wouldn't need to get an order because they already had it. So that was one thing that kind of overcame that barrier. But yeah, just as you said, most people were pretty thrilled about it. Yeah.
Yeah, and it's of course not an all or nothing process, and we're going to talk about the results in just a second. About, you know, this word deprescribing is a loaded word and means different things to different people. So for some it might be stopping, for others it might be reducing dose, using it intermittently, switching to something that has potentially fewer side effects or less pill burden or cost or other things like that. So let's talk a little bit about the results that you found. These are statistics, I think, Hafeez, from your patient population. Do you want to walk us through that?
Yeah, so in terms of the demographics, I mean, this is generally what you'll see in a long-term care setting. You'll have more patients who are in the, you know, 70 to 90 age bracket, more females than males. But this is so where we can get into the indication of PPIs. So, and it's you know, this is at first glance what I saw before actually doing the reporting. But you know, it seemed like 50%. I would look through patients' charts and see PPI, and I would look, okay, what's the diagnosis? And there was literally nothing there. So 37% of the 88 patients I had no indication, and you know, this was through chart reviews and you know, following up with families during care conferences. So I thought that was a pretty high number. The next category was, you know, potential GI prophylaxis. So if they were taking ASA for secondary prevention, or a long-term NSAID or a PRN NSAID, even if they were really sensitive to it, that's kind of what we categorized as category B. The third category was, and this is kind of a complex one, but and there wasn't really too many patients on this, but it was if they were taking ASA for primary prevention, which we know, you know, the risks may outweigh the benefits, and so that was something that, you know, we could potentially deprescribe 2 things in one. But that was only, you know, one patient, I believe. The fourth one is Gerd. So, you know, it's interesting that more people had no indication than people who had Gerd as an indication. But anyways, so that's if they had Gerd on their profile. Now we don't know exactly how that led to being a diagnosis. We don't know if it was you know, secondary to an ulcer. I mean, that's the type of thing that we might want to ask. But that's, you know, at first glance, that's the diagnosis that we had. And then the last one was, you know, something we would say is appropriate. So if they have an ulcer history, or if they, you know, have had refractory GERD that's been documented, where they just, you know, had to keep going back to the PPI despite lifestyle modifications and those types of things. Barrett's esophagus, or, you know, anything where, you know, we would say, you know, that makes sense. The PPI has more benefits than risk. We know there's risks, but the benefits outweigh that. So that's where I would categorize someone like that. But, you know, the letters were still sent for people who had that in case the physician said, you know what, I think maybe we should look at deprescribing. So that was also included in the letters that we sent. So when we did the intervention, sent the faxes out, waited to get the faxes back, refaxed if we didn't hear back, refaxed again if we didn't hear back. You know, that was, we talk about barriers, that was certainly one when I was doing this project. And, you know, as Carolyn said, you know, in person was definitely better, and a lot of these discussions were had during care conferences and med reviews. But in order to standardize it and to have documentation, I did send these letters just so that we had everything in writing, and so that we could kind of collate everything together. But, you know, when we did get the interventions completed, you know, 52% were completely stopped. So this is not a reduction, or this is not a PRN. This is they were on a PPI, ran the report, ran the report again 2 months later, and now they're not on a PPI at all. So that was pretty significant. And then, another portion of that had their dose reduced. Another portion had them changed to an alternative, so that could be ranitidine. And this project was done before the big recall, so that's something that's worth noting. So we did have some people that were on ranitidine or other H2RAs, and then we had some people who had their dose reduced, as I mentioned. So yeah, about a third of them did continue at their original dose, but 66% of them had either a reduction or a discontinuation or a change to what we would consider a safer alternative. So so that's the results of what we were able to do. And again, this is something that is ongoing. It's still something we continue to do, and it's something that we did before this project, but this is just kind of a way to show the impact that we're able to have by doing these practices.
Those numbers are pretty compelling. Thinking half of the people who are on PPIs or more have an opportunity to even look at that medication. I mean, that's massive. Again, there's lots of association with harms, but just even in terms of the burden of medication giving for the care staff, for the patient to swallow them, potential interactions with other medications, and that's a really big effect. I think that it just shows some your persistence in asking the questions, right?
I think the other thing is that 37% had no indication, but there was still another 15% that did have an indication, and we were still able to have reductions or complete discontinuations in those, and then the other 14%. So even if there's no indication, there's still room for deprescribing, and I think that's something else that's worth mentioning.
Yeah, and sometimes there's that, I know, having worked both in the hospital and the community, sometimes a patient is on a PPI, and I remember years ago assuming that the indication is reflux, when I really didn't know. So I was just trying to round out their medical history, and because maybe they can't communicate because of their dementia, just sort of making that assumption, and knowing now that Gerd is actually not very well defined, and there are objective tests for it that nobody does, and so there's a lot of assumptions that clearly went into getting into the state of things before you intervened. And you have some vignettes of just some examples of patients that you saw. I don't know if you wanted to read those or just tell us about these folks and kind of highlight their experience.
Yeah. Well, I can touch on them really quickly because I know that Carolyn has another project to go through as well. But really quickly, I mean, these are really, really common things that you'll see. So you'll see a patient who's been taking pantoprazole or rabeprazole or any PPI, and you'll look back at the history, you'll look back through the chart documentation, and they've been taking it since admission to the care facility, over 5 years. And through this whole time, there's been no documented indication. So we spoke with the nursing staff, spoke with the family. Nobody really knew why they were on it. So we said, okay, let's do a 2-week taper on this, see what happens. And everything was fine after that. So, I mean, it's crazy that it was 5 years, and who knows before that if they were taking it 10, 15, 20 years. We don't know that. But yeah, that's one case. And then the second one was with someone who actually did have a documentation of Gerd, and they were taking it. They were prescribed this medication while they were in the facility, so there was documentation of it being initiated. But since we were doing this project, I figured it was a med review. Let's see, have they had symptoms recently? No. Have they complained of Gerd that you can remember? No. It's been 2 years. And as we know through certain guidelines, we should be reassessing this every year. And so we said, okay, let's do a bit of a longer taper than for a patient who has no indication, because it is documented that they had symptoms when they were at the facility. And we'll talk about lifestyle modifications, and there's therapy departments and activity departments, and so by using that and by maybe reducing the portion of meals or little lifestyle interventions that we all know about, just having the conversation about that led to a discontinuation of a PPI in this case, just with a longer taper. So those are kind of where specific cases you might have a different recommendation. And these are just 2 residents. There's quite a few different ones, but those are 2 that I think are very common that I wanted to touch on.
Yeah, and that was pointed out in the chat that allied health providers like dietitians may have a really big impact. All right, we'll move on. These are Carolyn's slides. I know there's tons of great questions in the chat. I'm hoping we'll have lots of time at the end to go through them. Some of them will be answered by what's being presented. And you had a slightly different population and sort of breakdown of your long-term care patients. Can you tell us about that?
Yeah, so just to summarize, I guess most of our residents on PPI were female, almost 76%. And you can see that 50% of our residents were between 90 and 99, and another, 27% were 80, 89. So we had quite an elderly population. 24% didn't have any documented indication that we could find for the PPI, and then we made some assumptions and came up with sort of a likely indication for 36% of them. And then the others you can see there were ones where it was a bit more clear in the chart what it was started for. Our formulary in the hospital only has 2 possible PPIs, so we just collected some information on which ones were being used, and pantoprazole, esomeprazole were the ones that we have on our formulary. So this is just a breakdown of what we actually found. So in total, between the 2 facilities, which was at the time about 230 residents or so in total, 58 of those residents had an order for PPI at the time, 29 in Facility 1 and 29 in Facility 2. Facility 1 is a bigger facility with 150 residents, and Facility 2 only had 84 beds at that time. Facility 1 is the place where I go in person, and Facility 2, I don't attend the conferences at that facility. So overall, between the 2 facilities, we had a deprescribing rate of 62.5%. It was higher at Facility 1. We had about an 83% deprescribing rate and 41% at Facility 2. And I think that's probably just because of my gut feeling is just the in-person discussions that we were able to have about each of the residents. And on the next slide, I'll kind of go through the different methods that were used. But we did have some people that moved or passed away or over that 4-month period where we were looking at this. And then the other thing I should highlight is that after reviewing all these people, there were still a number that we felt really couldn't be deprescribed. 4 in Facility 1, and there was 14 at Facility 2. So yeah, you can go to the next one. That's great. So this is just the different methods. And so I did make a point of talking about the different options with the physicians every time we would meet to kind of say, like, well, we could try tapering. We could just stop at cold turkey, which isn't always our preferred method, but for some people who are already on a lower dose, that was our first stop. We could decrease the dose and see how they do for a while. We could switch to ranitidine. So by far the most commonly used method was tapering before stopping, with 63% of orders written in that way.
That's a little bit different than in the population that Hafeez saw. Do you think that was, like, what would you attribute that to?
I think that was kind of my preferred, that was kind of just my preferred method. I think just being a bit cautious. The residents live there. We can kind of keep an eye on them. We're not in a huge rush to do it, was kind of my thought. And that, if we can go down to a half dose for a week or 2, see how they do. And I see this physician every week, so we can kind of review that again after the 2-week taper, down a dose. And if things are still going well, we'd go to every other day sometimes, or sometimes we would just stop after the reduced dose for the 2 weeks.
Okay. And I'm trying to watch the chat. It's come up in there a little bit, question about rebound GERD or reflux. Because I think that's a concern for a lot of people. If there is a concern, is, well, if I reduce this, isn't it going to be so much worse when I'm off the drug? And there's some physiologic mechanism to that. I think it's hypertrophy of the goblet cells at the top of the stomach, and so there is overproduction of acid in, because of or associated with PPIs. So is that what influenced your decision to prefer kind of a gradual approach, or was it something else that
I think that's part of it. I mean, I don't know if for sure that happens to everybody, probably not. But I think it also gives some comfort to the prescriber and maybe also to the family, like, we're going to take it slow, we'll see how it goes. And if there's any concerns along the tapering, we can slow down the taper, we can go back up. So I just I felt like it gave a little bit of a safety net for if there was any nervousness about doing it. And it seemed to work okay. I think you'll see on the next slide that most of the people that were tapered were able to be successfully stopped.
Oh, I don't think I have.
I think it's coming up at some.
Okay, hopefully. Oh yeah, this is the follow-up. So why don't we jump to that? So you know, we were trying to walk through the project, sort of what your initial statistics look like, but obviously things change over time. And Carolyn, you had an opportunity to look back and sort of see what happened to that pool of residents, and sort of what the residents who are there now, what their numbers are like. I think, Hafeez, we have some of your stuff, but I'm going to jump ahead actually to Carolyn's first and then go back to you, Hafeez, if that's okay, just to follow up on that line of thinking.
This is just a breakdown of by method that we chose, how successful we were. So you can see there was like of the people who we tapered before stopping, so in the first column, 73.7 or almost 74% of patients were successful. We had one resident that had to restart, and that was at 69 days after they stopped. They had a recurrence of their heartburn symptoms, so they were put back on. And then we had one patient that moved and 3 people that passed away. Now, so we just counted those as not being successful. The student that I had did review all the deaths, and none of them were related to GI bleed. We wanted to make sure we hadn't done any harm, and they were unrelated, but we just didn't count those. So I would say, you know, for the most part, most people who were tapered did well with the tapering. There was 4 patients where we just kind of decreased the dose but didn't write out the full taper, and so they remained on that lower dose at the time of follow-up, and that's what that second column is. 5 people just had a hard stop, and one of those patients ended up passing away, which was not related to anything GI related, and then we had 2 that switched to ranitidine, and they were also successful. So I thought it was interesting just to sort of see how those people, even the people that did go to a hard stop, none of them seemed to have a restart in the 4-month follow-up. Oh, you're muted.
Sorry, I'm still muted. I think that's pretty amazing, you know, because you had such close monitoring, and that's one beautiful advantage of working in the long-term care facility, working with the nurses and other providers there, that you can look for signs of recurrence, or you know, and intervene again, because you guys are following these patients longitudinally, so you're always there to intervene. I think your numbers were a little bit different, Hafeez. Do you want to walk us through that?
Mm-hmm. Yeah. So the numbers that I showed about the results were taking this into account. So there wasn't a separate category for this. This was just they were included as continued on their original dose if this was what occurred. But yeah, no, I mean there is a physiological reasoning behind why rebound would occur, and so that was something that we were watching out for, which is why we didn't do a hard stop. Even if patients never had a diagnosis of Gerd, because you know if they were taking this for 2 years or 5 years or whatever the case, they would still kind of have a lower amount of acid production in their stomachs. So just in theory, you would think that by taking this away right away, we could cause that rebound. And so that's why we did the taper. I think there were very few cases where we did a hard stop, but in any case, afterwards we had about a 5% recurrence rate, which you know, when comparing to other studies that have done similar type of stuff, that was kind of the standard there, and I think that's a reasonable number, especially when you see the benefit of 66% were deprescribed. So I think this is just part of how a project is never really going to be perfect. But then a couple other things that I thought to mention that are totally outside kind of the clinical benefit. So not only is it reducing side effects or pill burden, but the cost. That's another big one. And so for us in the long-term care setting, I kind of calculated that if someone was to use a PPI regularly, daily, it's about $100 savings per year. And if you tell a patient it's pretty significant. Every year you're taking this. If you're taking it twice a day, you double that cost. But the other thing that's interesting to note is that PPIs are through special authority, and so if a patient, like we noticed, doesn't have an indication, they're going to be paying even a dispensing fee on top of that potentially, and that cost is going to the patient, not pharmacare. So that's purely in the long-term care setting. And, when we extrapolate this to the community setting, I know our project wasn't in the community setting, and, potentially doing this would have a different approach in the community setting, because you're not able to have charts and all those sorts of things. But, when you factor in markups and dispensing fees, I mean, this type of initiative or this type of awareness can save a lot of patients a lot of money. So just a quick summary there at the bottom, cost savings, and then reducing the risks of side effects from unnecessary medication, and subtract pill burden is a happy face. So.
I like that. There's a lot of satisfaction professionally that I think pharmacists, physicians can get from stopping a medication. We often think we want to fix a problem, so we want to prescribe something and make it better, but often in doing that we create this cascade of more problems. And so as you both said at the beginning, this is an easy place to start by trying stopping something, and you may not see any change in how the patient is feeling, except they may be relieved to have fewer pills or less cost. But it does open the door for those other things, and I think it can be pretty rewarding as a result of that. I wanted to talk a little bit about, again, Carolyn, we alluded to earlier, looking back further, some of the processes, like now, here we are many months, even years after some of the work was started. And when you look back, were there any things in the process that surprised you, or where we're at now, are there things that are different than you expected?
So this is originally, I first looked at it in 2018, and just this past spring, actually during COVID, when things were sort of a little slower for a few days, I reprinted the list, and I was really actually surprised to see that at that point we only had facility 1 because our second other facility had closed, but there were 23 residents back on PPIs 2 years later. And if you remember back, we had 29 in that building when we first started. But when I looked them all up, they were a different 23 patients. So one of them was in the original group and was still on it, and one was one of the people we thought we would never stop. And 7 of the people who we had originally stopped were still off. But then there was 22 new residents who were on PPIs. So that to me actually said a lot, because although we were successful with our targeting this class of drugs, and we got the numbers down fairly well, it creeped back up on us. And with the turnover of new residents coming and people coming from the hospital and the community, and there's they haven't had their med review yet, so they've arrived at the facility, but we haven't officially reviewed them in a care conference at that point yet. So those numbers did creep back up, and so I thought that was actually very interesting, that might be something that we have to repeat on a regular basis if we want to actually maintain sort of the behavior and the sustained decrease in the PPI use.
Hafeez, what about you? I mean, what Carolyn said is it's really interesting. It's kind of concerning because it means there's a lot of work ahead. And I think the hope would be that the work that you're doing would gradually kind of change the culture, within the prescribing mentality. But was this something that you also saw, or were there other things that surprised you about the project?
I think it's, to Carolyn's point, I mean, it's great that you did that report to kind of bring awareness to this. But I think it's a behavior change that will occur through projects like this, or webinars like this, or conversations like this, because a lot of cases, especially in long-term care, patients are admitted with these meds, and so it's not necessarily a physician who has started this. I think that's something that's important to note, because this is something that's been going on for a while, where patients were either discharged from hospital with it, or 10 years ago in community they had Gerd and they were put on this medication with no guidance to stop. So I think that's part of the reason for that. But I think another thing that is surprising for people when I talk about this project is, they're not necessarily surprised about the results. When you say 50% of people stop, 65% of people had deprescribing, I think they're not necessarily surprised about that. But what they are surprised about is the fact that we were able to do it. And I think there was a conversation about barriers earlier, and I think a big part of why this type of work doesn't get done is a bit of a perceived barrier with with physicians and how they might see it as you're saying that they're bad, or you're overstepping on their toes, or we kind of see this as being a negative conversation to have. But kind of what I noticed, and as Carolyn said, these conversations in person are great. We have the opportunity to have good relationships with our physicians and nurses and everybody on the team through these in-person consults. But this is part of being on an interdisciplinary team, and especially in cases where a physician has a resident that was admitted to them from somewhere else, or they were discharged from hospital and they're on this medication. I never had that sense where people felt that way. And part of it is, again, having that relationship. But I think at the same time, it's something that we need to not be afraid of, because we're all on the same team, right? We're all trying to optimize medication management and patient care and polypharmacy. And there's more attention being brought to this, which is great. But I think the surprise about that perceived barrier is something that we need to just pump the brakes on a little bit and say, it's okay to have these conversations. And once you get over that barrier, which I was able to, then I think we'll be able to continue this for PPIs and for other medications going forward.
Mm-hmm. Those are some wise words from you both. I'm going to give Erin Tijani an opportunity to gather some of the questions from the chat. There's all kinds of really interesting stuff. And just before we get into those, I want to ask you briefly about what's on your mind. What's the next thing you're looking at tackling, either in this project or a new project? Maybe Carolyn, I'll start with you.
Well, I think I'm going to have to re-tackle PPIs again. So when you do it the second time, it actually doesn't take that much effort to sort of reprint the list, talk to the physicians again, and redo it. And so even since we printed the list back in the spring, 50% of those people have been decreased or deprescribed already. So I think it's just, I find it interesting that to look at it by drug, because we're always approaching the patient at the care conference as the whole patient, and that's the ideal way to do it. But in some ways, I think as pharmacists, we see the different prescribing patterns from different physicians, but the physicians don't get to see that. And so I think the feedback I've been getting is that the physicians did appreciate seeing how many residents they have that are on a particular drug. So I think I will maybe tackle next with them, well, are there any other classes of medications that they'd like a report to look at where they're at with different other medications that we might want to tackle and see where they're at.
Awesome. It sounds really, really interesting, and you've been building those relationships through those conversations. So hopefully the next step will be easier. And Hafeez, what about you? What's your next project?
Yeah. So I think when it comes to PPIs, Carolyn did mention that this is kind of a problem that hasn't been fixed despite us fixing it for a year. It's right back at the forefront. So that's something that, like I kind of said at the outset, these are things that are occurring anyways through the med reviews, and I think summarizing it in a project format really brings more attention to it. So, the PPI conversations are still happening. They'll continue to happen. That's going to just be part of what we're doing. But I think, other projects, it's exciting that we were able to do this webinar because it brings attention to what we're able to do. But, statins is one thing. Antihypertensives, different blood pressure targets in the elderly is another thing. Dementia medications and risks and harms is another thing. Like, the list goes on and on. ASA and primary prevention, or atrial fibrillation, ASA. There's so many things. And I'm excited because Carolyn has had students at her location, and we're going to start getting students here, and we'll be able to have more support on doing those things. And so it's exciting, and there's definitely lots of opportunities. And again, these are not just one-time projects. It's something that's continuing to occur in our practice. But doing a summary or doing a project really just shows the impact that we're able to have.
Absolutely, you guys have made huge differences for the patients in your care, and I really thank you for sharing those experiences, those insights today, some of the challenges. I think Erin's been gathering some of the questions from the chat. There's a couple of new ones there. And just before we launch into those, I know we've touched on these very peripherally. but there's a ton of resources out there, and they're going to all be posted on the Practical PPI site. Some of the resources those watching may be familiar with, this is the Prescribing algorithm, which interestingly neither of you used specifically in your project, but a lot of what you did follows along the same things, because this is based on the evidence, right? It's a summary of best practices from the evidence that is available. There's videos that go along with how to use this. The Choosing Wisely Canada organization has a whole toolkit about quality improvement and deprescribing PPIs, as well as some recommendations from gastroenterologists and others. And CADEN, the Canadian Deprescribing Network, has a wonderful handout that might be helpful for patients, maybe not in long-term care, or maybe for the families to review. And there's links to all of these resources on that website. So I'll just, Erin, are you ready to bring up some questions for the panel here?
Yes, I am. Thanks for the excellent presentation, and Jessica, you're an excellent moderator, so I appreciate that. Just a reminder to everyone to do your evaluations, especially if you want continuing education credits. Okay, so let's get to the questions. Is it widely known that PPIs can cause hypomagnesemia? Any of you have a comment on that?
I don't know if it's widely known. It was definitely part of our rationale for starting it. But Carolyn, you were gonna say something?
Yeah, no, I agree. I don't know if it's I don't think magnesium would be like something that would be typically monitored with regular blood work in a long-term care facility, but I will often ask for it to be added if someone is on a PPI on their yearly blood work, just to see where it's at. Yeah, but I think it gets missed.
I might be able to answer that. A lot of the harms, again, there's no randomized controlled trials that are very long and that are well-powered to look at harms or that look specifically at all of these. So when I did a talk for the Long-Term Care Initiative in Victoria, which is posted on the TI website, and I referred to a couple of different systematic reviews, and feel free to look on, tweet us or look me up through our website and email me, and I can send you those reviews. But again, there's some association, but the strength of the evidence is poor. So I don't use that as a justification, but just my interpretation.
I think in terms of just minerals and reduced absorption, B12 supplementation, it's kind of, when you stop a PPI, you're able to 6 months later stop a B12, and I think that just speaks volumes about what these initiatives can do and the prescribing cascade that occurs. And so I think B12 is more commonly seen, but I mean, it is, I did a project, a directed studies project when I was in school, and hypomagnesemia was seen in labs because it was a hospital-based thing, so you have more access to that. So it is known, but I think supplementation for magnesium isn't as common as B12 in the long-term care setting, so that's probably why it's not as well known. But it certainly is something that's been documented and that we were aware of.
Great, thank you for those answers. The next question, it's actually a point of clarification. So if a PPI is needed for Gerd, places like Choosing Wisely suggest 8 weeks of PPI, reassess, and then if it's still needed beyond that first 8 weeks, then yearly reassessment, as opposed to starting a PPI for Gerd and then reassessing, the first reassessment point at 1 year. So any comments about that the first reassessment point would be 8 weeks?
I can tell you, that comes from the drug monograph, 4 to 8 weeks, and in one of the past TI letters, an older one, I can't remember which one, but it is linked to on the Practical PPI site. We looked at that, and the consensus from the literature was somewhere between 4 and 8 weeks was the duration needed to treat symptoms of reflux. So I think that's where that number comes from, if that's the question. I don't know, Carolyn, did you know?
Yeah, that sounds right to me. Yeah, okay.
It's just that inertia that occurs. I mean, most of these PPIs were already there, but it's the inertia that occurs, and they don't have that guidance of the 4 to 8 weeks, which is the case. Yeah.
Another question: do prescribers prefer face-to-face conversations, or are they the faxes and letters working? Did you have any formal or informal feedback about the way they wish to be engaged in a discussion?
I'm sure it's probably very dependent on whatever is the culture at your facility, but I know that for me, the face-to-face was very valuable. And if I couldn't do that, I would opt for a phone call. But I think it just depends on, you know, whatever the culture is where you're at, and if you're actually co-located in a building, or if that's more difficult. But I mean, by fax, you were actually able to deliver a letter that had a lot more information in it and standardize what you're saying, so that has advantages too.
One of the other comments related was that it'd be more efficient potentially to have an electronic dashboard of prescribing, and I guess that's what other organizations have done in the UK, where primary care prescribers can log into their profile and see de-identified prescribing patterns of others. So you can, in addition to face-to-face or faxes or letters, you can actually sign in and see your data live.
Right. I think for me, it was just a matter of sometimes you're not going to be able to connect with someone over the phone or in person. They might not be there that day. So for me, it was just I just wanted to get it done, I guess.
Oh, yeah.
Yeah.
And another question here, any feedback on what happened or why patients were not chosen to be candidates for deprescribing? Like for the people that said, no, I don't want to do it, do you have an understanding of what the reasons were?
I can recall a few where you know, they'd had a GI bleed, they still had to be on an anticoagulant, or I think there was one who was on rivaroxaban and had to be on prednisone and had had a previous GI bleed. So there was some specific kind of clinical situations where we felt the patient was too high risk, and that we would want to keep them on.
Yeah, I think that's a great question, because you know, sometimes we think just very tunnel vision on one condition, but if a patient has behavioral issues and a potential reflux rebound could cause an outbreak of those sorts of symptoms, or that's something to be considered. And I mean, it's not ideal. I mean, by the book, it doesn't sound appropriate, but I mean, when you look at the whole picture, you have to think of everything. And so that would be maybe another case where someone, you know, may have an indication of Gerd, and you might be able to reduce the PPI, but the risks in that specific case might outweigh the benefits, because you know, there's a lot of residents and nursing staff that are looking after that resident, and so maybe down the road is something to consider, and getting that conversation started is good. But yeah, that's another thing that was worth bringing up.
Great, thank you. A couple of comments related to allied health professionals or partners in the team. So any comments on getting nurses or dietitians on board with either motivating prescribers or being supportive in terms of these initiatives, or helping monitor the impact of deprescribing?
Dietitian was the dietitians at the facilities were very, very helpful, because they noticed B12 deficiencies in so many residents on PPIs, and I think for the majority of the facilities, I had a conversation with the dietitian before starting the project, and so they were actually, you know, getting the conversation started with the physicians as well, and so that was a big help. And then nursing would be monitoring the patient quite regularly for those symptoms. So nursing and dietitians were the two health professionals that were really helpful in this initiative.
I agree. I had the same experience in my facility. The only thing I would add maybe for me is the recreation therapist can also give you a lot of information. So, you know, they have meal programs, or, you know, they can tell you a lot about whether the resident has changed since you've discontinued the medication. Are they participating less? Are they avoiding different foods? Especially if people have dementia and they're not able to maybe communicate with us as well. I found that they always had a lot of insight into the residents, and that was sometimes helpful as well.
Great. And related to that, Bev posted a comment about a newsletter they prepared for doctors and nurses, and then they made posters in lay language that they put at the entrance to the extended care units to educate the family. And as a result, they had family members requesting deprescribing initiatives. So not only can you get dietitians and nurses involved, you can get the families interested by targeting some of your advertising to them. One of the other questions I'll move on to is histamine 2 receptor antagonists. Any notable references in terms of the harms associated with those drugs, especially compared to PPIs?
Well, for myself, I always thought of H2RAs as kind of like the step below the PPIs, and so with the harms, it was kind of the same. I'm not sure if Carolyn or Jessica want to go into further detail, but H2RAs aren't perfect as well, but it's still kind of a step down in the way that I looked at it.
Like harm reduction. I guess the ability of them to lower the pH of the stomach, or to change the pH of the stomach, is going to be less intense. So that's, I guess, the theory.
I think with the recalls, it's been really tricky, and I found it easier in my population to I use the alternate day dosing model to kind of further decrease the overall amount of drug that they're getting, because my logic is that they are tolerating the PPIs. They're not having adverse effects that are distressing to them, otherwise I would have stopped it sooner. So I feel like just working with the same drug and decreasing it rather than exposing them to a totally different class of drugs, although probably safer on balance. I think it's just easier to use it less frequently, and so I usually decrease the dose, and then I switch to, if I'm going to do a taper, switch to Q2 days, and then leave a PRN order that almost never gets used. Then I just don't have to think about ranitidine and whether it's available and safe. But that's out of convenience. There's no strong reason beyond that.
Okay, great. One person suggested including, or that they have experience in including a few weeks of, say, ranitidine at the end of the PPI taper to smooth things out, and are asking if that's overkill, or if any of you have tried that or considered that or know anything about that.
I don't think we did that with anybody. There was one physician who that was their preferred method. So the people that we had that switched to ranitidine, that was sort of that physician's go-to method, and those people were all successfully eventually taken off. Maybe with patients, like if people are really nervous, to kind of go with nothing, it does give them that feeling like we're still giving you something, and it just prolongs that period to make them feel more comfortable to come off of the medication. I'm not sure if that could be part of it too, just the psychological help for coming off of something.
Sure.
I think just, the interesting thing about, the algorithm we're looking at right now, or anything else that's been brought up as a resource, Carolyn didn't use those, I didn't use those, so there's no really exact right way to do it. There's no, if you don't do it this way, you're wrong. Like, there's none of that. So if that's an approach that someone wants to take, I don't see an issue with that. And I think just getting the conversation started is the main thing, and it's great that that's another method. And there's other people who are doing things that are similar to this in their own way. So I think that's great.
Yeah, I wanted to show the algorithm because obviously some evidence has gone into it. But if you look at the website, you'll see more of a breakdown of that. And on the Choosing Wisely and the Caden websites, you'll see too. It's kind of murky, so having that discussion with the patients, caregivers is probably the most important part if you're not sure what's best. And, TI's looked at the comparative efficacy of different PPIs. I don't think we've ever done anything comparing H2 blockers, or there was a question in the comments in the chat about combining H2 blockers and PPIs. I think a lot of that's just working in the kind of evidence absent zone. Doesn't mean it's wrong, right? I think just figuring out what's going to work best for the patient that's the easiest thing to do, because the science is lacking. So that close monitoring, and I think that's where I rely on the nursing staff too, especially with frail, demented elderly, that monitoring for those nonverbal signs of distress and other things like that tells me if what I'm doing is working. And if it isn't, then there's lots of ways I can change my plan to suit that particular patient. So it is very individualized. I think that's what you guys did, right? You looked at every patient, what was their indication, and then tried to figure out what would work for them. And that takes a lot of work, but ultimately that's probably why you had such, or I think that's why you had such success, because it was tailored to the person using the best evidence that you could find, right?
Great. I'm going to offer a comment myself. If you're going through a medication review and you notice a proton pump inhibitor and it takes some investigation to figure out the indication, then you can stop that cycle and then try to institute indication-based prescribing, or make a note in the directions, take one tablet for reflux symptoms, and then put a note that detail gets put on the label, so that the next person that comes around doesn't have to do the extra work that you did to try to figure it out. So that's a simple way to pay it forward. I just want to note the time, Jessica. There's about 3 or 4 minutes left, so maybe I'll pass it off to you for some last words.
Yeah, I think, oops, just see the slideshow here. Wanted to make sure you have the contact information. Well, I wanted to thank everybody for joining us and spending your lunch hour with us. Hopefully you'll do your evaluations. We'd love to hear about the format if this conversation was helpful. I know there's a lot of interest in specific data and lots of questions about what the best thing is to do with PPIs or what the associated harms are. So I'd really encourage you to go to the website, to the practical PPI section, where you can find those resources, and feel free to send us any questions, comments, tweets, whatever, and we can forward those on to Carolyn and Hafeez too if you have specific questions about the interventions that they've done. I want to thank you, Carolyn and Hafeez, for opening up your worlds to us today, and I know it's tricky because you put a lot of work in, and so to just reduce it to a couple of slides conveying the numbers, it doesn't really do service to all the hard work that you've put in and probably the impact that that's had on patients. So thank you for that work and for joining us today. I hope that I can leave the two of you to give us your final words, any messages of encouragement or tips going forward before we end this conference today. Carolyn, I'll start with you.
Okay. I guess I would just say that it doesn't have to be a project. Like if you're out there thinking about how can I do something where I work, I never started this thinking it was going to be a project. It was just the way that I was going to try to tackle something that I thought I could make a difference doing in the kind of limited amount of time that I had to go to that facility. So it doesn't necessarily have to even be something that you're going to create graphs and create a big study about, but if you just sort of tackle one group of drugs and even find one doctor that wants to work with you on it and just start with that and then go from there, you can start small.
Hafeez, what do you think?
Great. Yeah, well, I mean, first off, thanks to Jessica, Aaron, Eric, and Carolyn. It's been great doing this, and I'm really happy that this was put together to bring awareness to all this. But I think, yeah, it's just, there's no one-size-fits-all approach to this. But I think, you know, this is the type of work that is probably happening anyways in a lot of settings, and this just, I think, brings attention to it. And so it doesn't have to be a project. If you know, sometimes, as you can see, I mean, in my case, sending letters and faxes and having a spreadsheet and tabulating it and then writing an article and then doing, like, it is time consuming, and it doesn't have to be like that. Like, it's something that I just did. I just enjoyed it a lot, but I think it doesn't have to be like that for everybody. I think even specific patient successes can be huge, right? Like, you have a conversation with a patient, they get taken off a PPI, they don't need to take their B12 supplement anymore, they're saving all this money, they have peace of mind that they didn't have, you know, the risks of side effects that could occur, and that's a victory. It doesn't have to be a huge project. It doesn't have to be something big. So I think that's kind of what I'd leave everyone who's listening to this and thinking about how they can implement this into their own practice. It can be individualized for sure. So that's what I would say.
That's fantastic. Thank you both for the encouragement. I think we've got some practical tools. We've got your advice and your experiences to guide people and hopefully inspire them to tackle PPIs or something, some other medication in their facility. So On that note, thank you everybody for joining us, to Choosing Wisely Canada, the Canadian Deprescribing Network, and Deprescribing Org, as well as the Long-Term Care Initiative in BC for spreading the word. We hope that you'll join us for future webinars. Thank you. Goodbye, everyone.
Thanks, everybody.
Bye.